Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha from Roots Community Health Center, reporting for the week of October 4th, 2021. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Alameda County now has 115,200 recorded COVID cases. That's about 1,200 higher than last week when I reported. And 1,349 Alameda County residents lost their lives to COVID-19. That is about 20 above what I reported last week. Vaccines continue to increase, and we are now at 91.3% of those 12 and up having had at least one dose, and 78.3% of those eligible being fully vaccinated. Oakland is trailing just behind at 90% and 76% respectively. As you can see here, cases continue to trend down. The top graph is showing daily cases, and the lower graph is showing the 14-day cases. And although it is still quite a bit higher than it was at this time last year, we certainly are coming down after this larger than expected summertime surge. Now, if our past experience is any teacher, which it should be, we can expect cases to come back up. It's hard to say when, most likely in the winter time, and that's due to a combination of the virus factors of when it replicates more, as well as behavioral factors like when we travel more or get together indoors more. And so now is really time to make a push to do what we can to flatten that curve, to decrease the spread so that we won't peak as high as last winter. And we do that primarily through getting more people to be vaccinated so that we can reduce the number of replications of this virus, reduce the chances of worse mutations, and also, of course, to protect the most vulnerable, which include all of our unvaccinated people, as well as those who are immunocompromised or may not have mounted a good response to the vaccine. So today I wanted to try to unpack a little bit what I know a lot of us have been hearing about really almost for this entire pandemic, which is about natural immunity. You might remember earlier conversations about natural herd immunity, and now of late we are hearing a lot about trying to compare between natural immunity and vaccine immunity. And this all turns out to be very complicated. It's not a very easy thing to measure or draw conclusions from, but that's not stopping a lot of people from drawing conclusions. So I'm going to do what I can to try to break some of this down. A quick overview of our very complicated and amazing, really, immune system. And it can be broken down into two categories, which is innate immunity and adaptive immunity. I'm not going to spend a ton of time on this, but I just wanted to kind of at least briefly go over this, because the innate immunity is really kind of like our first responders. And so these are what immediately go into action when we are presented with an infection. So this starts immediately and it dissipates in just a couple of days to a couple of weeks, and this includes a lot of different types of cells like our macrophages. Those kind of engulf the invader and chop them up. And then you've got dendritic cells, which are really kind of special. They process the antigens into to a form that is more adaptive, which is the second kind of category of our immunity. And so the adaptive immunity is something that kicks off later, and it lasts longer, like even for years. And sometimes adaptive immunity can even last an entire lifetime against certain types of pathogens. And so the adaptive immune system includes our B cells, which we know make antibodies, and they actually make a whole bunch of different types of antibodies. Won't go into a lot of detail, but these can be both naive and also memory B cells that can generate antibodies. And so when they're memory B cells, it means that they're kind of like waiting around until their memory gets refreshed with reinfection or re-exposure, and you make antibodies. Then you've got our T cells, and they also make a lot of different like CD4 and CD8 cells. And so these are really an important part. This adaptive part is really a very important part of our immune response. And I'm going to get into a little bit more why this is so important to this conversation in a moment. But this kind of helps to explain why the antibodies, and including the antibody tests, are not kind of the end all be all. The B cells can be on standby and make the antibodies when needed. So just because you don't have antibodies to everything flowing around in your bloodstream all the time, that would just be overkill and not needed. But those B cells have that memory, and they can make the antibodies later when it's needed. And T cells are also really special. They can actually attack cells that have already been infected. So the antibodies will actually kind of scavenge and get rid of the antigen before it can attack the cell, and then your T cells can attack the cells after they're infected. So we have sort of this whole entire army of all different types of fighters, and what I've explained to you is really just a few of them. Now, when it comes to this natural immunity versus vaccine immunity, there are definitely theoretical pluses and minuses to each kind of immunity. So it really isn't right to say one is just better than the other. There's a lot that would go into actually determining this, but I'll talk about just sort of in theory first. So natural immunity, basically your body gets exposed to the entire virus. And so in the case of SARS-CoV-2, that means you get exposed to the spike protein and the membrane protein, and all the other parts of the virus get presented to your cells. And so your natural response is going to include antibodies as well as a cellular response to more of the virus, to the whole virus. And so that could be theoretically a plus, but viruses are pretty clever, including SARS-CoV-2, as we know, and it actually has ways to kind of shield or hide parts of itself from your immune system. And so it is not the case that you will always develop a full complement of antibodies and cellular response to natural infection. And this seems to depend a little bit on how severe the infection was. And so more severe infection typically means a stronger immune response. And so with those who maybe got a milder case, they may not end up with as much of a response as those who got more severely ill. But COVID has been so unpredictable that there's not sort of a hard and fast rule, at least not that we know about yet, about what to expect in terms of how big of a response you mount correlating to how severely ill you became. The other thing, of course, it depends on is the host. So the person who gets infected, how strong their immune system is. We know that the immune system is much stronger in young people, and then it gets weaker as we get older. But there is a lot of variability as it relates to the host as well. And that is actually true for both natural immunity and vaccine immunity. Now, with vaccine immunity, we know that it is more specific in the sense that the vaccine really took advantage of the part of the virus that we know is causing the most problem, and that is the spike. And specifically, a certain domain on the spike that binds to our cell receptors called the receptor binding domain. And so, in theory, this is an advantage because it is much more specific. We don't need a bunch of different antibodies necessarily against different parts of the virus that aren't the part that attack our cells. And so, in theory, it is sort of a more targeted response that we could be generating. On the other hand, it could become a disadvantage later if in the future some of those mutations, new variants, if they evolve so much that the spike protein, let's say, looks completely different, or let's say that's no longer the part that's causing the problem, or, well, we don't really know what the future may hold in terms of mutations. And so what we've got now has been quite amazing in terms of the vaccine being able to cover not only the wild type that it was developed against, but also all of the variants that so far we have been grappling with or concerned with, or the variants of concern that we're dealing with now. And so far, we don't have a SARS-CoV-2 variant that evades the vaccine. And so far, going with the spike receptor binding domain has been a good bet. And so, in theory, that is a more targeted response than natural immunity, but again, could become a disadvantage if future mutations evade the vaccine. So, kind of what I think really got this conversation stirring, and what I've seen reiterated and publicized quite a bit in this topic, is a study from Israel, and it is still in the preprint stage, so it has not been peer reviewed, it has not been officially fully published. But of course, in COVID time, that is not stopping anybody from picking it up, and the media kind of taking it and running with it. And that is certainly happening here. And that's not to say that it's not good information, but I'm going to kind of break it down a little bit. So, what this study did was they actually took data from the country's second largest HMO, basically, and they looked at data from June 1st, 2021 to August 14th, 2021. So, this was during a time when they were in a Delta surge. And they actually did a few different models to look at and analyze this data and compare three different groups. They looked at a vaccinated group, so fully vaccinated with Pfizer before February 28th, 2021. The second group is a natural immunity group that was PCR confirmed COVID infection also before February 28th, 2021. And then the third group was both infection and vaccine group, basically people who were previously infected with SARS-CoV-2, recovered, and received one dose of Pfizer by May 25th, 2021. And they did a lot of comparing, and I don't want to get into sort of the complicated way that they compared it and modeled it, but I'll just give a few highlights. They were able to control for some things like age and socioeconomic status and gender, less so for people's actual behavior. And I think that's actually really, really important for a study like this. And the bottom, and so what they found is that, sort of in order, the best protection was people who were infected and then got a vaccine dose. And the second group was the natural immunity group. And the last group was the vaccinated group. But what's really important here is, first of all, the actual infection rate was extremely low across the board. 1.5% or less of those in the study were infected in any of the groups. So this is pretty small. There's a pretty small percentage here. Also, there were no deaths in any of the groups. So I think that was important as well. And again, the highest level of protection seemed to be those who had gotten infected and gotten a dose of vaccine. And they did show that those with natural immunity were infected less. And the amount of hospitalizations, it's sort of hard to say if it was statistically significant or not, but it was slightly higher in the vaccine group. And a few just things to point out, and again, this will go through peer review, and there will be people who do this much more than I do, but just a few things to point out, which I think are of note, which is that we have to account for behavior. It's very difficult to actually do a study like this and not account for behavior. And if what we're seeing, just anecdotally or here in the United States, we don't know if it's the same as in Israel or other parts of the world, but certainly those who are vaccinated tend to feel a bit more protected, because they are, and may have behaviors that could expose them further. Also, people who are vaccinated tend to be vaccinated because they know that they have either underlying conditions, they're older, and they're concerned about becoming infected. So there's already sort of differences between the groups before we even study anything. So the people who tend to be vaccinated, just like we're seeing here in this country, tend to, we have much better coverage of the vaccine in older people and those with immune issues. And so it's really kind of hard to do these studies in this way in the free world because these are not controlled environments, and we know that people's behavior is going to be different. And these are sort of confounding factors as we try to make sense of this all. But I think probably the most misleading thing that happened, and this isn't necessarily an issue with the study itself, it's really an issue with the way it has then been reported back out in the media. And the biggest problem is that the study does not account for the people who did not survive. So the natural immunity didn't work out so well for 4.55 million people worldwide. Their natural immunity was not enough to keep them from dying from SARS-CoV-2. So to just ignore that or to not account for those people and have a headline that says natural immunity is better than vaccine immunity, well, perhaps for those who made it, for those who survived, but there's so many people who did not. And we know now, sadly, that 701,000 people in the United States have lost their lives to COVID-19. Natural immunity was not enough for them. So to then just focus on those who did survive, we just need to be really clear that that is what we're doing. So we can't just simply say it's just better to get infected than to get the vaccine, because we know that about 1 in 56 people who get it will die if they're not vaccinated. And so, and the chances of this happening if you are unvaccinated are about 25 times higher. So those facts still remain. So I think it's really important that we be careful when we talk about natural immunity to qualify that by saying for those who don't die. Now we also have this study that was published in the MMWR in August, and it was looking at the state of Kentucky, and it was similarly looking at people who with previous infection versus those who were fully vaccinated, and they essentially found that those who were not vaccinated were almost 2.5 times to become infected compared with those who were fully vaccinated. And so this is kind of saying almost the opposite of what the Israeli study was saying. But again, when we are looking at these pockets of studies that are not really controlled, they're sort of looking back and they're doing their best to match the different groups. But again, we're not able to account for all of the different variables. And so I want to sort of talk a little bit about what would be needed in order to come up with some better conclusions, because I think we have a huge gap. And I think some of the confusion comes around because when we're talking about what happens if you've been vaccinated, what happens if you're not vaccinated, what happens if you've had previous infection, is it tends to get confused because sometimes we're talking about the risk of getting reinfected. Sometimes we're talking about the risk of getting sick, getting symptomatic COVID. Sometimes we're talking about severe infection. Sometimes we're talking about death. And so I think that the data is very overwhelmingly clear. I've gone over it a number of times here that the overwhelming majority of deaths and hospitalizations are now in those who are not vaccinated. But I think if we want to get down to the individual piece of, am I protected or not? If I've had COVID, if I've had the vaccine, and this is something that I know I've repeated quite a bit about, we need some tests for immunity. And so I wanted to point out this study, which is also in the preprint, but I think it's just very well done and kind of illustrates some of the complexity of what we're dealing with. This was a study that took a very deep look over time, took 61 patients. They took 342 samples over time, and my understanding is this study is still in progress, so I look forward to getting even more sort of updated data. But what they did was take a very deep look at all the parts of the immune system, many of the ones that I just covered. They looked at antibodies, and you can see that on the left, and as expected, those are kind of decreasing over time, and that is what we would anticipate. But what is really striking is that the memory B cells in the middle there, and even also the T cells, they sort of are holding really strong even after 6 months, and in some cases even increasing. And so, without getting into too much of the detail, because there's quite a bit of detail, and it's just a very sophisticated way that they did this study, and they're doing this study. But basically, what it is letting us know is that the vaccines, the mRNA vaccines in particular, are inducing very durable immunity and immune memory to SARS-CoV-2 that continues to evolve over time, and in some cases even looking like it's increasing even at the 6 month mark. And so the SARS-CoV-2 specific memory B cell response is very robust after the mRNA vaccine. It's continuing for at least 6 months, even as those antibodies are declining. So this is kind of showing why just doing an antibody test really is not enough. The mRNA vaccine was able to generate memory B cells that were able to actually bind to the variants of concern that we've been dealing with. So even though the vaccine was made against the wild type SARS-CoV-2, the memory B cells that were generated by mRNA vaccination are actually able to bind to the alpha, the beta, and the delta variants. And those B cells were generated new antibodies that were actually able to fight off or bind to those variants. And this seemed to be superior to those memory B cells that were generated by milder COVID-19 infection. And so again, this is a small sample if you're trying to really draw big conclusions, but what I think is important about this study is it's showing us how it's happening and what is actually happening in an individual person, and hopefully gives us promise for the future of what we'll be able to determine with some more sophisticated diagnostics. And then lastly, the SARS-CoV-2 specific T cells, the memory CD4 cells, were stable between 3 and 6 months post-vaccine, and in the vast majority of those in the trial, they had still very robust CD4 T cell responses after 6 months. So the bottom line of what this is showing us is that there was durable cellular immunity. So cellular immunity is not something you hear talked about. You talk about antibodies, you talk about they catch COVID-19, but this was really looking at that more complicated but very important cellular immunity. It was durable for at least 6 months after mRNA, and hopefully we'll continue to just get more data as time goes on. So at least 6 months after the mRNA vaccine, and the high quality memory B cells were persistent. The strong T cells, CD4 T cells were persistent in the majority of those individuals. And so the other thing I thought was important about this study is that it kind of gives us some insight into what feels like discrepancies that we've been hearing, right, about vaccine effectiveness, because sometimes we're hearing about well, it's not preventing infection like we thought, but it is preventing severe disease. So what's really going on? And what this study was suggesting is that because the antibodies do decline over time, that is probably why we're not able to immediately sterilize that SARS-CoV-2 if we're vaccinated and we're exposed. So even if we can't immediately sterilize it because the antibodies are reduced, that cellular immunity is kicking in, and it is lasting some time, and it's creating what they're calling a rapid recall response. So like a memory that won't let that virus keep replicating itself for very long. It won't let it spread aggressively in the individual's body. And so even though the infection occurred, it is preventing that severe disease, the hospitalization, and death. So this goes deep in trying to quantify what's happening with all these multiple facets with our immune system, and what we'll need, I think, to really get a handle on things as we go forward. And so, for example, this kind of analysis or information will be important as we look at how important are boosters, and how are the mix and match studies going. So is it better to have a different vaccine than the first one, and so on. And also The best advice we can give on timing for giving the vaccine after an infection and whether that should be 1 or 2 doses. Right now, the guidance is, as we have reviewed many times here before, those who've had infection should become vaccinated because the natural immune response is too unpredictable. And we know that actually, if you've had COVID-19 and you get a dose of an mRNA, it looks like you will have superior protection. And right now, the guidance is still to get 2 doses, and hopefully, as time goes on, we'll get a little bit more specific guidance on it. But right now, that is at least the most reassured that we can be, just because of all the unpredictabilities that I've mentioned before. And so, until we get more of that individualized data, we are, of course, going to be continuing to really be considering all of the layers of protection that we need, which is not just a vaccine, although that is the strongest by far layer of protection that you can possibly have. We also need to be thinking about all of our layers of protection as it relates to the modes of transmission of SARS-CoV-2. And we know that the primary method of transmission that we're most concerned about is aerosol transmission, and we're concerned about that when we are indoors, when that aerosol can accumulate. So first and foremost, we want to avoid crowded indoor spaces as much as possible, particularly with people you don't know, people of unknown COVID status and unknown vaccination status. If you must be in an indoor setting, then a high filtration mask, the highest one you can tolerate, ideally will be an N95 or a certified KN95, because that is the only mask that's going to actually filter those SARS-CoV-2 particles from getting to you. And we want to ensure that if you are indoors, there is good ventilation and high filtration. And so those are the filters on the HVAC system or even a HEPA filter. In order to protect ourselves from droplet transmission, again, we need a mask. For this, the high filtration is probably not the most important because the droplets are typically larger, but certainly, again, what you can tolerate is the highest you can tolerate is always the best. But if you are, let's say, outside, you really just want something to block those droplets from hitting your eyes, nose, and mouth. So a shield, barrier, and or a mask, as well as just the physical distancing. If you're far enough away, then those droplets are unlikely to hit your nose, mouth, or eyes. And lastly is surface transmission. And really, in order to prevent surface transmission, we can take care of the vast majority of it by just washing our hands. But we also know that that doesn't happen as frequently as we would like. It needs to. But in the meantime, don't touch your face. Wearing a mask will certainly help keep you from touching your nose and mouth and eyes. I see a lot of people rubbing eyes, touching their nose, and so on. It's unconscious. So wearing a mask can kind of help you to at least not touch your nose and mouth. And then, of course, sanitizing and disinfecting, especially our high touch surfaces. And as a general rule, open spaces are safer than enclosed. Further away is safer than close together. And shorter time periods are better than longer time periods, particularly when you are indoors. If you get symptoms, get tested right away. And remember, those might be headaches, sore throat, runny nose, sneezing, in addition to the typical loss of taste and smell. Not everyone gets a loss of taste and smell. Cough, shortness of breath. If you believe you were exposed, get tested in about 3 to 5 days and isolate yourself until you get your results. If you test positive, please do what you can to get your close contacts to get tested as well and isolate themselves as well. And if you are positive and in a high-risk category, please inquire about monoclonal antibody treatment. It can be life-saving. And remember to optimize your immune functioning, take a multivitamin supplement, consider additional vitamin D supplementation, manage your stress, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10. See you then.